An ounce of prevention. How can you mend a broken heart? How can you stop the rain from falling down? How can you stop the sun from shining? What makes the world go round? The Bee Gees, song released in 1978. It is said that an ounce of prevention is better, and likely to be both cheaper and healthier, than a pound of cure. This is a partial response to comments made by Dr. Dawn Scantlebury, head of the cardiology service at the Queen Elizabeth Hospital, and head of the Heart and Stroke Foundation of Barbados, made in a recent newspaper article dated January 8, 2025. Her comments address the national health picture from a point of view of hospital or tertiary care. I am not in a position to challenge most of her comments, and in fact I agree with many of her conclusions. But I am willing to share some thoughts about primary care, mainly the polyclinics in Barbados. One reason that I am not in a position to challenge her comments is that, since 2012, we have not had a published annual Chief Medical Officer's report detailing statistics about healthcare and health services in Barbados. Certainly the CMOs between 1976 and 2012 have made this information available, but this access suddenly ceased after 2012 for reasons not publicly announced. It is unclear whether we will ever get the statistics of the last dozen years, and whether we will be afforded any sort of analytic data on our health situation in the years to come. Most of our data we get in snippets, when one of our local health officials makes a public statement, or we read articles in the international media, or from multilateral health organizations like WHO and PAHO that highlight some aspect of health in Barbados. I had the misfortune of quoting the QEH CEO on figures given for new cases of chronic kidney disease 2 weeks previously in a local newspaper article, only to be corrected by a hospital nephrologist who suggested that the situation was twice as bad as that described in the newspaper article. Just around 2012, the Ministry of Health, now the Ministry of Health and Wellness, were quick to announce to the public of Barbados the introduction of computerized electronic health records in many, if not all, of the public health clinics, including the QEH and the polyclinics. One interpretation of this was that we, the general public, would have ongoing access to activities in our health services, and analysis of such data would or could lead to rationalizing public health services, hopefully leading to improvement in the provision of healthcare nationally. Patient information could be moved electronically between primary and tertiary care, thus facilitating a smoother patient flow. Instead, based on a patchwork of anecdotal data, our health services seem to be getting worse, and we are getting less, not more, information. As Dr. Scantlebury pointed out, the hospital is seeking to employ 300 new staff, including 43 clinical specialists. This is likely to send our national healthcare bill, which, compared to 1980, one of the earliest years in which an annual report on the nation's health was produced, rose 850%, while the population growth in the same period was 24%. While I am no financial expert, it is difficult to see this level of rising expenditure being sustained. Instead, our polyclinics seem to be suffering from being under-resourced, both in terms of staff and equipment, and quite a few patrons are dissatisfied with the services offered or not offered, the length of time it takes to get an appointment, and the chronic shortages of pharmaceuticals. This dissatisfaction has brought out some angry individuals. About 2 weeks ago in the USA, there was a high-profile assassination when a senior official of their health insurance industry was shot dead in broad daylight. The public response seemed to focus on the unacceptable service being offered by the medical insurance companies who seemed to put profit before people, and much sympathy was extended to the alleged shooter. It is not clear whether this episode will cause any change in the behavior of the health insurance companies there. We have had in Barbados over the last few months incidents where polyclinic staff were threatened or actually beaten by patrons dissatisfied with the service being offered, or denied, at the polyclinic. The MOHW's response has been offers to improve the security, rather than to focus on the dissatisfaction of the patrons with the service. I hope we don't wait until someone is killed or seriously injured before this is addressed. While public service announcements from the MOHW suggest that only persons with medical emergencies go to the Accident and Emergency Department, AAND, the lack of an effective health information campaign to educate the general public on what conditions constitute a medical emergency, and the not infrequent reports of persons who were apparently well collapsing and dying, suddenly elevates many a non-emergency condition to that of an apparent medical emergency. It is not a coincidence that, in the absence of health promotion and disease prevention, one of the pillars on which national health should be built, we see a proliferation of private emergency clinics, and we have an avalanche of patrons flocking to these emergency clinics and the AAND department. If many of these are really medical emergencies, this is further testimony of the current inability of our primary care services to preserve health and prevent disease. Perhaps one day we will have the hard data to confirm or refute this theory. Another challenge with the polyclinic staffing is this. Many of the doctors who are attached to the polyclinics are UWI trained, with the UWI undergraduate medical course being very heavily hospital medicine focused. The one-year internship period after graduation is also hospital biased. There are many differences between hospital medicine and non-hospital medicine. The MOHW, in employing these doctors to work in the polyclinics, encourages them to gain additional training in public health, the Masters of Public Health or MPH degree, a course that emphasizes statistics and epidemiology, but not clinical medicine. The patrons that attend the polyclinics have clinical problems, unearthed by the NCD and now also the COVID pandemic. Obesity, for example, is associated with over 200 clinical problems and may require cardiologists, nephrologists, dermatologists, gynecologists, obstetricians, mental health specialists, internists, and others. Our polyclinics are rarely staffed with any of these specialists, but these are the health problems that the polyclinic attendees present with. So many of these doctors are not sufficiently trained and/or lack experience to manage any of the many clinical problems faced on a daily basis. On the other hand, UWI also offers a postgraduate course in family medicine, which is a clinically based program, which also includes a mental health component, and some other Caribbean countries, but not Barbados, have tried to build up the clinical expertise in their polyclinics, or health centers, by requiring their doctors to be trained in family medicine. Outside of the Caribbean, many places are now requiring physicians who wish to work as independent medical practitioners, IMPs, GPs in our scenario, to complete training in family medicine before being allowed to practice. Our last major study of national health, the Health of the Nation study, was published in 2015. This study of 1,234 adults aged 25 years and above identified many weak areas in our national health. For example, 66% of persons interviewed were overweight or obese, as noted above, conditions that put these individuals at risk for a large variety of medical problems. Many of these persons had been diagnosed with diabetes and/or hypertension, but the study also found that large numbers, 43% of persons with diabetes or hypertension, who were offered treatment, did not have their condition controlled. Uncontrolled diabetes and/or hypertension leads to heart attacks and strokes, here averaging 1 and 1.5 each day. These conditions fill our AAND department, our hospital wards, and even our cemeteries. But these are also conditions that are initially seen and treated in primary care. Our primary care clinics are unable to adequately manage large numbers of patients with these conditions. In the foreword to the HOT-N study, our current CMO, who at that time was the Senior Medical Officer of Health with special responsibility for the NCDs, stated, "The HOT-N results will provide vital information to assist governmental agencies, civil society, and the private sector in the creation of a robust policy and program environment for the prevention and control of NCDs in Barbados." 10 years later, we are still awaiting this robust policy. Meanwhile, persons are suffering and dying. At a January 2025 edition of Ask the World Bank series, a World Bank executive noted that a lack of urgent policy implementation could escalate a dual crisis of health and economic instability in the Caribbean. At this same forum, Dr. Heather Armstrong, the head of chronic disease and injury at the Caribbean Public Health Agency, raised the call to increase healthcare investments, particularly in prevention, to improve NCD outcomes and boost economic performance. She said prioritizing prevention provides a significant opportunity to lower healthcare expenses while enhancing national productivity. As the Bee Gees suggested in 1978 with their song, "How Can You Mend a Broken Heart?" If your starting point is a broken heart, it may be very difficult to stop the rain from falling down. It is easier to preserve a good heart than to fix a damaged one. It is easier to preserve good health than to offer a patch to fix a damaged product. So while Dr. Scantlebury is calling for increased resources to be channeled to the QEH, I am calling for increased resources to be channeled to primary care offices. While she is calling for 43 clinical specialists to be employed at the QEH, I'm calling for a number of family medicine specialists to be employed in primary care. We do have a large study that has identified weak areas in primary care. We do not have a similar study of tertiary care here, but a number of anecdotal stories, phone calls to the radio call-in programs, or an occasional video clip generally suggest dissatisfaction with tertiary care, particularly the prolonged waiting periods in the A&E department and the prolonged time spent in the A&E department waiting to be transferred to the wards once hospital admission has been confirmed. Our primary care clinics can benefit from additional staff and additional resources to reduce the workload on the A&E department and on our hospital wards. Our primary healthcare centers must be offered an opportunity to practice health promotion and disease prevention. As I stated on the first line of this article, an ounce of prevention is better and likely to be both cheaper and healthier than a pound of cure.